It's noon, and there may still be a few other people coming in, but I think in the interests of respecting your time and those of you who came on time, we'll get underway. So for those of you who don't know me, my name is Jason Foster. I'm director of Parkland Institute at the University of Alberta, and we're very glad to have all of you attend us today on our latest report release, a report that's in conjunction with the Canadian Centre for Policy Alternatives. And so looking forward to these two esteemed researchers that we have who wrote this report on our behalf, talking to you a little bit about what they have found about and what this might mean for the healthcare system going forward in Canada. Before I move on to the business of the webinar, it's important to acknowledge that the University of Alberta, where of course the Parkland Institute is housed, is located on Treaty 6 territory. It's the traditional home and gathering place for diverse Indigenous peoples, including the Cree, Blackfoot, Papachase, Métis, Nakota Sioux, Iroquois, Dene, Ojibwe, Saulteaux, Anishinaabe, Inuit, and many others. And as we gather today, virtually, to try and sort of learn from one another and to share, I think it's important that we carry both with us the understanding of the knowledge that Indigenous people can bring to conversations such as this. And so I think we need to remember that importance that Indigenous communities have, and understanding that we all have a responsibility to one another. We all have an obligation to take care for one another. And given that today the topic, of course, is healthcare, I can't think of anything that speaks more directly to that particular commitment that Indigenous peoples can carry, can help bring all of us moving forward on that issue. So we will be presenting for, the webinar will be for an hour, hopefully be about 30 to 40 minutes of presentation from our two speakers. And then we will then open it up to a Q&A. I mentioned the Q&A at this point to sort of get you an understanding of how we're going to run this. If you'll notice at the bottom of your screen or wherever you have your little menu bar for your Zoom, there's a little Q&A icon. So we won't be having people kind of ask their questions directly. You can type your question in to the Q&A in panel. I will then be sort of looking at them all. I may combine a couple if they're on similar topics, and I'll try and do my best to get to as many of your questions as humanly possible. So I mentioned that because even as the presenters are talking, if your question does come to your mind, you can type it into the Q&A right away, so it's in the queue already. And obviously you can do that as we go. So do not use the chat function because the chat function, only the organizers of the webinar will see your. So if you have a question for the organizers because you're having technical problems or whatever, feel free to contact us. But the other participants in the webinar will not be able to see you in the chat functions. Now, without further ado, let me introduce and then pass things over to our two esteemed speakers today and the report authors. First is I actually don't know which order I meant to ask them. I don't know who's going first, so I'm just going to introduce them in the order that I feel like. And I'm going to start with Rebecca Graff-McRae. She is a research manager here at the Parkland Institute, where her areas of research include public health care, seniors care, and public services. She holds a PhD in Irish politics from Queen's University Belfast and has previously had fellowships with the Institute of Irish Studies at Queen's, Memorial University Newfoundland, and the University College Cork. In addition to many reports for Parkland Institute, she has worked many important pieces of work that she has done for Parkland. She's contributed to the Canadian Centre for Policy Alternatives Alternative Federal Budget since 2022, and her work has been featured in local, provincial, national, and international news outlets. And I think, as her colleague, I would be remiss if I didn't also highlight recently, she was awarded the Ethel Mead Award for Excellence in Research by the Ontario Health Coalition. Certainly a high accolade, and we wanted to make sure it's all acknowledged because we're very proud of her for that particular achievement. Her partner in research on this project is Andrew Longhurst. He's a senior researcher and political economist at the Canadian Centre for Policy Alternatives. He's also a PhD candidate at Simon Fraser University. His research has been published in academic journals and by research institutes, including the CCPA and us here at Parkland, and Canadian Journal on Aging, Political Geography, and other publications. His recent publications include Haul It Out for the CCPA, Operation Profit, which he did for us at the Parkland last year, and At What Cost, also for the CCPA. As an expert on health policy and finance, his commentaries appear regularly in news media across the country. And so without further ado, I will hand the virtual mic over to Rebecca and Andrew and let them walk you through things.
Thank you so much, Jason, and thanks to everybody for joining us on your lunch break here. I'm gonna do the magical thing with the slides and hopefully get those going from there. Um, Sorry, we did do this a test run. There we go. So I'm going to give a little bit of an overview first of the report, of the legislation, the notorious Bill 11 at the center of this report, and a little bit of the myth busting around some of the claims that is being made through this legislation. And then I'll pass it across to Andy to dig further into some of the implications of the logics that are built into this legislation and the risks for our wider universal single-payer healthcare system from there. Right. I just want to set the scene a little bit. Amid a manufactured economic crisis and subsequent workforce pressures, a former media personality turned conservative premier tables Bill 11 to establish two-tier healthcare in Alberta. Its objective? To deconstruct the definition of hospitals, to carve out lucrative services for private for-profit contracts, creating non-hospital surgical facilities. Earlier versions of the legislation had proposed dual public-private practice and permissible patient fees for enhanced medical services, raising concerns about the cannibalizing of the public system, preferential access, the risks of U.S. corporate competition, and financial and ethical conflicts of interest. But this was ultimately watered down by vociferous federal pushback and large-scale local protest. The bill is the Healthcare Protection Act. The year is 2000. So a quarter century later, this might all sound uncomfortably familiar, but there are three key differences between the context of Smith's Bill 11 and Klein's Bill 11 that make this moment, I feel, even more urgent and potentially damaging for universal public health care. The first is the continuing and deepening exhaustion, a hollowing out of the healthcare workforce in Alberta as well as nationwide in the wake of the COVID-19 pandemic. The second that builds upon this sense of exhaustion and feeling of overstretching our healthcare workforce is that Bill 11 is just one part of a massive transformation of healthcare structure, governance, funding, and delivery in Alberta, sort of notably and almost epitomized by the dismantling of AHS as the single provincial healthcare authority in the province. Anybody who's got a keen eye might recognize this little picture from the archives. That is the Calgary General in the corner. And the final thing here is, to the point of my little vignette at the beginning, Smith's government is not starting from scratch on two-tier healthcare. Klein's legislation, even though compromised and watered down from his initial vision, opened the door. It opened several doors to enable this government to enact a fully fledged, fully realized two-tier system. And their previous legislative interventions over the last year have also increasingly centralized control and decision-making powers within cabinet, within the office of the premier, and within corporate providers. Page. So where to start with Bill 11? Bill 11 is an omnibus bill that amends the Health Statutes Amendments Act to overwrite all of the major legislation that sets out the blueprints for healthcare in Alberta. And it does so in an unprecedented way to create the first two-tier system in Canada. And when we say two-tier, we mean one that explicitly and very deliberately provides faster access to those with the ability to pay privately and longer public wait times for everyone else. And this openly upends the foundational principle of Canadian Medicare, which is access based on medical need and not on the ability to pay. So the bill permits dual practice by those physicians choosing this sort of term flexibly participating to determine on a case-by-case basis whether a medical service will be billed to the public insurance plan. Here in Alberta, it's called the Alberta Healthcare Insurance Plan, or directly to the patient or a third-party insurance plan. This, as you might gather, creates perverse incentives, both on the part of physicians and a greater administrative burden for physicians and for the system at large. No other province allows this. So this model that's been put forward in Bill 11 is unique in Canada. Prior to the passing of the bill, the status quo across the majority of provinces was that public-private was an either-or. It's in or it's out. And physicians have to elect whether they're going to be within the public system, billing to that public insurance plan, or choosing to directly bill patients by unenrolling. In Ontario, physicians are not even permitted to unenroll from the public plan. And all of this was designed deliberately to prevent things like double billing, which is billing both the public plan and privately for the same service, or extra billing, which is adding patient fees on top of the billing that goes to the public plan. And it's also meant to prevent patients paying for preferential access. So these are guardrails that have been put into our version of healthcare. One of the reasons for that, as we've seen recently in Quebec, they now require their doctors to commit to working 5 years in the public system before choosing to opt out and go private, due to a massive exodus from their workforce away from the public system, which was becoming unsustainable and untenable. So while the Smith government believes that Bill 11's model promises flexibility for physicians, a flexibility that will attract and keep them working here in Alberta, the goal behind this is ostensibly to remove this financial risk of physicians completely opting out. As we've seen with that decision-making control being put more and more in the hands of cabinet and corporations, a lot of this decision-making is already being taken away from physicians themselves. We can look to Charles Rusnell's recent expose on chartered surgical facilities, which I'm happy to go into a little bit. So while the Alberta government has attempted to justify Bill 11 as this promise of flexibility, it's also claimed as this tool to reduce wait times. This is also a myth. So as an extensive body of evidence internationally, as well as emerging evidence here at home, demonstrates, private payment increases public wait times. And when you create two systems, you haven't magically sort of cloned the workforce needed to deliver that care. The proponents of these types of systems, the Premier herself has said, this is supposed to be like removing people or allowing people to remove themselves from the public queue in order to shorten that queue for others who are waiting. As our very outspoken advocate for public health care, recently Dr. Braden Mance has framed this really differently, and I think it's quite a stark example. Rather than just removing those patients waiting in the public queue and sending them off down the other track, they're taking their entire surgical team with them. The OR nurses, the anesthetists, the surgeons, and in many cases, taking that actual space and infrastructure with them as well. So this leaves those waiting in the public system with fewer hands, fewer resources, and more complex and urgent cases to resolve with ever less. As we can already see in our system, this is triggering a negative feedback loop. For the private market, this is a feature and not a bug. There is no business case for a private market without long public wait times. If everyone could get seen quickly and painlessly within either system, if there was no difference between them, why would you need the redundancy of two? So a private market creates this incentive to further erode and hamstring the public system to drive more business into that private stream. Um, it also puts that sort of ethical and moral conflict onto individual physicians, where they may be tempted to make their own public wait lists longer to drive business to their private streams. Okay. And at the same time, the private market for medically necessary care also drives up costs. There's no cost savings argument that can be genuinely made from this type of proposal. And it drives up costs both for the third-party insurance plans and for the public healthcare insurance plan. We've seen from all sorts of private for-profit contracting out in Alberta and across the country. These investor-owned facilities need to build in a profit margin. They need to offer attractive compensation for physicians and other healthcare staff. They might need new infrastructure if they are not leasing a former Alberta public hospital for $1. They might pad in some administrative or facility fees, which are now permitted under legislation in Alberta. And through all of that, the cost of this basket of medical services just spirals. The public plan has to compete, or it faces an increasing financial burden that will be used politically to justify narrowing the scope of services that are insured. So all of this becomes a race for the bottom, leaving fewer public options and fewer affordable options for patients. And I'll hand over to Andy.
Thanks, Rebecca. So, building on what Rebecca said, this legislation is important and unique and quite concerning in the broader Canadian context because it creates the first private healthcare insurance market for medically necessary physician and hospital services covered under the Canada Health Act. We know that already 3.3 million Albertans already have extended health insurance coverage, and this is primarily through employer-sponsored plans. And so what we see with this legislation is this is very likely the place that private insurers will build out their offerings to cover medically necessary procedures, including surgeries. Surgeries, elective surgeries would be a main one, as well as diagnostic imaging. Right now, we have 68 active insurers in Alberta, and only 3 are not for profit. So, this is an industry overwhelmingly dominated by commercial for profit insurers. And the risk here is that we see a significant movement into the market of now not only, it's not just extended healthcare insurance, but it is an insurance market for medically necessary care that duplicates what is insured by the public health insurance plan or the Alberta healthcare insurance plan. But the growth of this private insurance market will depend on a number of factors. We're still awaiting the regulations that the government said it will bring in, and it will depend how much of the physician and surgeon, nursing, anesthetist, and allied health professional workforce moves into this duplicative private tier, this two-tier system that is created with this new private pay market. Are we going to see employer-sponsored plans offer queue jumping insurance? I think that's really the intent of this legislation is to build out from where the market already exists. And I think we will also have to see whether hospitals will be forced to compete with for-profit surgical facilities that are called chartered surgical facilities for patient revenue via private health insurance as well as out-of-pocket payments. And on that point, point, it seems likely that hospitals will be encouraged to compete, and this is based on the provincial government bringing in a new funding model for hospitals. Next slide, please. And this is partly because Bill 11 muddies the definition of what a public hospital is in Alberta to one that can be completely operated by for-profit entities. It changes the language. And we have to keep in mind that the intent of hospital insurance legislation historically in every province, as well as the intent of the Canada Health Act, was to prevent physicians and facilities from charging patients directly. So Bill 11 creates a private health insurance market as well as a provider market. So facilities delivering the care, it's a market in that way as well, where now every patient is seen as a source of revenue. And the thing about the way that private health insurance markets work is that there is a selection bias. And that's because the healthiest and the wealthiest are going to be the most profitable patients to insure, not patients who are disproportionately lower income, who are have multimorbidities. These are patients that are going to be unprofitable in a private insurance market. And these are folks that are largely not going to be able to obtain access to private health insurance in order to pay to be at the front of the line. Next slide, please. But I think what's really important with this legislation is the risk of US control by way of investors, US investors coming into the newly created Alberta healthcare market, both the insurance market for medically necessary care, as well as the provider market, facilities providing care. And what Rebecca has outlined is that there has been successive legislative changes that have been intended to create a provider for-profit provider market by breaking up Alberta Health Services as one of the most important parts of that. And so what we are likely to see as Alberta moves in this direction, it is likely to attract US investment interest. We live next to the largest for-profit provider and insurance market in healthcare in the world. It's the United States. And at this current geopolitical moment, I think we need to be very aware of the risks that are very likely to play out with the growth of this private health insurance market in Alberta. And this is not speculative. In a 2023 Canadian Centre for Policy Alternatives report, I documented U.S. investor interest. There are institutional investors that are interested in looking at this market. At the time, it was limited to the surgical outsourcing markets that were becoming increasingly significant across the country. Alberta is one such market. Ontario is now a growing market as well. But now we're introducing a much larger market, which is private health insurance for medically necessary care. And what is important here as we go into renegotiations with our trade agreement with the United States and Mexico, these trade agreements historically have provided limited protection against the entrance of US investors and insurance corporations. So that is to say, once they become entrenched within the Canadian context, it will become virtually impossible to get them out. And I think the important point here is that we won't have US style healthcare. We will literally have US healthcare by the fact that it will be these corporations that will be here in the market. And I think we need to think carefully about what this means. Is healthcare privatization and the growth of healthcare markets here, especially concerning the growth of the private healthcare insurance market, is this an entry point for US control and domination? And what risks does this pose to Canadian sovereignty? Next slide, please. Importantly, domestically, we also need to think about Bill 11 and its relationship to the Canada Health Act. The Canada Health Act is the overarching federal legislation and framework that compels provinces to have public health insurance plans that are consistent with the principles outlined in the Canada Health Act. And after careful review and analysis of this legislation, I think it is very likely that the Bill 11 legislation, as it's currently written, violates multiple sections of the Canada Health Act, including the criteria of universality and accessibility. And the accessibility language is worth repeating right here, which is that the public health insurance plan must provide insurance on, quote, uniform terms and conditions and on a basis that does not impede or preclude reasonable access. And it's quite clear that based on providing preferential access, a two-tier system where you have private payment to be able to have care provided more quickly, that is at odds with that accessibility criteria, as well as the universality criteria. And what does this mean for Alberta patients? The Alberta budget is comprised of about 28% of federal dollars that flow to Alberta as federal health transfers through the Canada Health Transfer to fund public healthcare services in the province. So if, as we're suggesting, Bill 11 violates multiple sections of the Canada Health Act, Alberta puts in jeopardy nearly a third of its healthcare budget. So what happens in the situation where those dollars are no longer flowing to Alberta? Do many services, are they just not provided? So it raises a number of pretty significant questions. And I think there are a number of other significant questions that we can't answer today because we need to know more. And I think, unfortunately, this legislation has been passed with no guardrails, no clarity on the extent to which dual physician practice and two-tier healthcare will take shape. And importantly, the section in the legislation on dual physician practice has not yet been proclaimed, so it is not yet in force. And we also, from the government, understand that they will be bringing in regulations to accompany this legislation. And that is an open question. Will there be any guardrails? We haven't heard any specific other than the possible intention that it will be limited to some surgical specialties. But again, we don't know. We need to know more. And so far, we've had silence from the federal government. Will this change? Will the government provide its response to Bill 11? I think we need certainly to hear that. And in the absence of the federal government stating whether this legislation violates the Canada Health Act, it does raise additional questions, and those include whether civil society organizations in Alberta and across the country perhaps will be compelled to seek a court order to force the federal government to enforce the Canada Health Act. And there's another open question, and I think really at the heart of this report, which is, will other provinces follow Alberta's lead in introducing two-tier healthcare and a private health insurance market for medically necessary care that is already insured publicly? We've heard Premier Scott Moe in Saskatchewan already talk and suggest that that province may follow Alberta's lead. So this is a significant moment for public health care in this country, and very significant for the implications as they relate to the Canada Health Act. Next slide, please. And with that, we really appreciate you joining the webinar and look forward to your questions and the discussion.
Great. Thank you so much, Rebecca and Andrew, for this really excellent overall overview of your report. We'll move to the Q&A session in just a second, but just have a couple other little business items that I want to get to before we move to the questions. First, I meant to mention at the beginning, but neglected, is that the session is being recorded, and so we will be posting a video of it on our YouTube channel shortly afterwards. So if you do want to share it with people, or know someone who didn't get an opportunity to catch it, they can sort of check it that way. Also wanted to highlight for those of you in Alberta that Friends of Medicare is organizing a series of urgent conversations about this very topic over the next month or so. They're kind of going around the province and having conversations and meetings in various towns and centers to talk and highlight both the fears that I think, the concerns that both Andrew and Rebecca have highlighted, the length of the various yeah, the schedule of the events has just been posted in the chat. The Edmonton one is going to be Sunday, February 22nd at 2 o'clock at the Edmonton Expo Center. We'll feature Dr. Paul Parks as one of the speakers. Tomorrow night, if you happen to be in Hinton, is Hinton. The night after that is Leduc. And then some others. So keep an eye on that particular webpage as they add more events as the month moves along. So let me, without further ado, move to some of the question and answer. I do think some of them got answered during the presentation, hopefully, because I think some of them do seem like Andrew and Rebecca didn't talk directly. But let me try a couple of clarification questions first before we move into some of the more broader implication kind of questions. I have one question saying, how is Bill 11 creating the first private health insurance market for insured services when there's already varying degrees of privatization in other provinces like Quebec and New Brunswick? And I might just pair that um, with what was the scale of the exodus of doctors from the Quebec public system before their 5-year policy was adopted? I thought we might as well start with a couple of comparative national questions, and I'll leave Andrew, you and Rebecca decide who might be best positioned to answer those.
Sure. Thanks, Jason. And thanks for those questions. I can jump in and then Rebecca can jump in if she wants. First of all, what is significant about this legislation is it creates a new class or category of physicians, and they are termed flexibly participating physicians. And this is what makes this legislation particularly significant and unique in the Canadian context is, as Rebecca explained, across the country, you don't get to concurrently be in the public system and then also be in the private pay market. You have to make a decision. Are you going to be in one or the other? And to be clear, what we have seen across this country is the issue of unlawful patient fees or unlawful extra billing, where physicians and facilities are continuing to engage in those practices of accepting private payment or requiring private payment while they're still enrolled in the public insurance plan. But what is really important and needs to be underlined here is the fact that this legislates two-tier healthcare and legislates dual physician practice, which is the method by which two-tier healthcare takes shape. And so that's important. And then I think secondly is the point about a private health insurance market. So far across the country, we do not have private health insurance for medically necessary care covered under the Canada Health Act. So this is what makes this particularly alarming, is it starts to introduce that duplicative tier of private health insurance where physicians, surgeons, and the for-profit health facilities that they're working in are going to be accepting private health insurance for those medically necessary services that are already covered under the public plan. That's what makes this distinct from what we see across the country. And there are some limited exceptions. And I think just around the point about the exodus from the public system, Quebec has been a province where there has been the most movement out of the public health insurance plan. So it's called RAMQ. So there has been movement across, but a lot of that movement has actually been in family medicine to move entirely out of RAMQ, the public insurance plan, to bill patients privately. But that is distinct from what we're seeing with Alberta, which is legislating two-tier healthcare and duplicative private health insurance for medically necessary services.
And just to jump in on the Quebec example, what was the intention behind Bill 83, which was passed in, I think, spring, April of last year, which put in place this mandate around ensuring that Quebec-trained doctors were committing to that 5-year term within the public system, was, I think, the impact that in or out choice was having on the sustainability of the public system. So what was found at the time was between 2020 and the introduction of the bill in spring 2025, the number of physicians choosing to opt out and to work exclusively in the private network had jumped by 80% in 5 years. So what the bill that I referenced there is about establishing a different type of guardrail to say, we can't have physicians opting out if we can't guarantee that we're maintaining a certain level of coverage within the public system concurrently. And that was the intention of the bill there.
Great, thank you for that. Again, I think I'll start with get some questions of clarification and about the report itself. There's lots of questions about implications, what we can do about it. I'm going to try and group those as we move along in the conversation to create a little bit of flow. So another sort of specific question. You talked about how the legislative changes made over the last year has centralized control and decision-making powers within cabinet and the office of the premier. They're asking basically if you could point to, be more specific about some of those changes that you're referring to that centralized control and decision making.
Well, first of all, I think it's very clear to anyone who's been watching the healthcare refocusing process here in Alberta over the last 3 years that this is being driven very directly and very openly by the Premier herself. And that she has telegraphed many of her own intentions and her own vision of what our healthcare system should look like long before following up on that with legislative changes and structural changes. So there's a clear sense that the driving force behind this comes from Premier Smith herself or from her advisors, donors, friends. But also then we look to some of the larger pieces of legislation. Bill 55, which was passed in, again, late spring last year, was also an omnibus bill, which amended the Health Statutes Amendments Act. That poor thing has had so many facelifts in the last couple of years. So I would point to Bill 55 and the ways in which decision-making and governance structures around healthcare delivery was altered by that act. Some of the direct examples I could give you, in addition to the splitting of healthcare delivery between the four new successor agencies, and the ways in which those agencies now report directly to their health adjacent cabinet ministers. Things like public health, for example, our chief medical officer of health, public health inspectors, anyone in those types of oversight and public safety roles within public health now don't have a clear line of decision making and responsibility within an arm's length agency. They report directly to cabinet. And so there's been a lot of questions raised since Bill 55 about the independence of those types of healthcare roles, the type of advice and oversight that they can provide. There are also provisions within Bill 55 that are built on in Bill 11, which give a lot of decision making to third-party providers, particularly things as fundamental as when to discharge patients from their facilities. So those have historically been medical decisions and are now increasingly being handed over to become corporate decisions.
Great, thank you for that. One person was wondering, they said that at one point we were told that privatization would reduce labor costs and create more and better paying jobs at the same time. They're just wondering if there's any evidence that shows the accuracy of those claims.
Well, it shows quite the opposite when you have a two-tier system. You're going and certainly private health insurance introduced for medically necessary care. You're going to be increasing your costs because folks, surgeons, anesthetists, operating room nurses, technologists, folks will migrate to that private tier where you often work 8 to 4 schedules, daytime schedules. You're not on call. The cases are low complexity. Keep in mind that in a lot of these for-profit facilities, the procedures, the cases that are being performed are these are very stable patients. They don't have the risks associated with patients who have more complex conditions. So you're going to be working with low complexity patients. Those cases are easier. And in the context of a system that is, as many would argue, is collapsing or has collapsed, certainly I don't think anyone is faulting clinicians for moving towards work where you have better work-life balance, where you have not the chaos that you're confronting every day within our public hospitals because of the immense pressures and challenges they're under. So what we see in other jurisdictions, and again, the US with a largely unregulated two-tier system, is you see that it becomes very difficult to contain healthcare costs in an environment where people are moving towards that private tier. And so that is very likely to unfold within the Alberta context, keeping in mind that the quote, flexibly participating physicians can determine on a case-by-case basis. And if they're working in a private for-profit facility, I think it's very likely that we will see these facilities move towards a model where they require that those surgeons working under their banner are going to be charging privately for services. It's going to bid up the cost of their labor. This is pretty straightforward economics in terms of where the movement of the workforce is going to go. And it's borne out by a large body of evidence, not only in the academic research, but we had a significant charter challenge led by the CEO and orthopedic surgeon, Brian Day, of a for-profit surgical facility in Vancouver. And that we received a judgment that canvassed extensively the international evidence about dual physician payment and a private tier, a two-tier system. And it found that it did not serve the public interest. And so that charter did not go through. It was ultimately rejected at the trial level, and ultimately the Supreme Court of Canada decided it didn't want to hear the case. And we can assume because the trial judgment provided such clarity in terms of the evidence that was brought to bear. So, put simply, it's going to be very hard within this context to contain costs within the public system, and then for patients, it's going to be an unconstrained market for the services that we all depend on to access them privately and jump to the front of the line.
And just to add very briefly, for anyone here in Alberta who memories are short, if we remember the downfall of DynaLife in terms of delivering lab services was directly a result, not directly a result of their own choices, directly a result of the stipulation that the employees that were transferring from Alberta Precision Labs to DynaLife had to do so under the same or similar collective agreement conditions, the same compensation. This issue all hinged upon retirement plans and benefits and sort of differential over time. DynaLife went into this contract, and this is the record show, thinking that their profit margin could be boosted on the back of these small differences between their compensation to their employees and what APL staff were being compensated through the public funding. And that was challenged successfully through the Alberta Labor Relations Board. DynaLife was told they had to pay equally, and that was ultimately the straw that broke the camel's back. They said that wasn't sustainable. They couldn't make a profit on the contract. And that's what caused the folding. So we need to look at these examples and say, if you can, you're saying you can't make a business case in delivering these services privately unless you're undercutting your labor. Then I think there's a big look in the mirror moment for all of us there.
Great. Thanks, Rebecca. Um, Just a couple, maybe two related quick ones, and then we'll start talking about kind of what can we do and how do we move forward on this. First, one participant is just sort of asking for clarity about whether primary care is defined as medically necessary under the Canada Health Act. And then a second question that kind of jumps from that and maybe is a nice transition question for us is how do you, the two of you anticipate these recent legislation will affect the existing primary care networks in Alberta, in particular in terms of how they approach billing and the structure of the way in which they provide services. So we'll toss those over to you.
Thanks for those questions. So medically necessary services or publicly insured services for the purposes of the Canada Health Act and formerly under the Alberta Healthcare Insurance Act were physician and hospital services. So these are under the Canada Health Act required to be provided without financial barriers. Now, this is dramatically changed under Bill 11 and its amendments to the Alberta Healthcare Insurance Act. So so I'll take a step back. We don't in the legislation have services, the type of services, physician services and hospital services that are defined as those that can be where physicians can work as flexibly participating physicians. So that is to say, the legislation is all about giving the ability of physicians and surgeons the ability to work as flexibly participating physicians in a private pay market. But the legislation doesn't say if there are any constraints to it. So right now, as it's written, and if it were brought into force as it's currently written, it would mean that all physicians and surgeons that provide publicly insured, medically necessary services could charge privately on a case-by-case basis based on their determination for those services. And there are no constraints on that. So what we are hoping to see from the government is clarity around what are the constraints that they have in mind. Are there going to be any constraints? Now, if I were writing this legislation, I first of all would have that defined in the legislation itself and not leave that to the regulations because the regulations don't require the legislature to pass them. Those happen by cabinet. So it leaves the ability for government to make changes without much public scrutiny at all. And I think that's the concern here is these changes have been so dramatic to the nature of public health care in the province that they are being done so in a way that does not provide safeguards and also doesn't provide public scrutiny.
Great, thanks, Andrew. So we've got a bunch of questions revolving around kind of what can we do about this. So I'm going to try and break these down into a couple of subtopics, subsections. And so maybe we'll start off with kind of the elephant in the room here, because Andrew, you had mentioned, that this likely is a breach of the Canada Health Act. And so so there's a number of questions revolving around what can the federal government do? What should the federal government do? And what has the federal government done in the past with similar kinds of actions taken by provincial governments? So I guess people are just trying to understand is if there's something we can look to the feds to try and help us with this.
Just on the last part, since I invoked the specter of Ralph in this hallowed space, I guess that one's on me. In the past, and when I alluded to Klein's initial proposals for what he very clearly expressed a desire for an open two-tier healthcare system for Alberta and spent many years pursuing that. In the case of his Bill 11 was a very contentious back and forth between Klein, represented by the provincial health minister, I believe it was Ivar Johnson at the time, and Alan Rock, the federal health minister. So in this case, Rock initiated these types of inquiries in an informal sense to the Alberta Health Minister, wanting clarity on the legislation, wanting clarity on, as Andrew alludes to, are there any guardrails? What types of limits are going to be put on this? And then stating very clearly what his government's position on the Canada Health Act was, and that without any of those amendments, then they would consider this legislation to be in violation of that, and there would be consequences from that, as Andy alluded to, around clawbacks with the Canada Health transfer as well. So the fact, on the one hand, this didn't get to an official consequence. But there was a very clear back and forth from Ottawa to Edmonton, saying, prove that this is on side. And they weren't able to do that without amending the legislation that would go through. In the past as well, there have also the federal health ministers have used their prerogative to issue an interpretation letter, which is sort of like, essentially, this is our interpretation of the Canada Health Act. I love the thing. I celebrated its birthday, last year, but it's not a particularly thorough sort of document. It was designed for a different place and time in many ways, and solving a particular set of problems. And so in the past, some federal health ministers have issued an interpretation to say, we believe that these types of actions would fall in or out of the act, and we would pursue consequences based on that, if that helps.
Okay. So the second kind of category of questions is if as it sort of, you were kind of implying, Rebecca, that, we shouldn't really be looking at the federal government to be the white knight to come in and save us on this. Is there other legal avenues that we can take? Are there other groups that could launch legal challenges against this bill, either based on the charter or the Canada Health Act itself? Is there something we can do without having to wait for the federal government?
I can jump in there, and then I think Rebecca might have more to say on this as well. Certainly, I mean, there are patient groups, advocacy groups, citizens groups that would have likely a standing with the court in terms of making a compelling argument about how this impedes their access to timely healthcare services, and is again not consistent with the certainly the accessibility and universality principles set out in the Canada Health Act. And I think it does require us to think about what those possible remedies are. And I think moving forward, if we have provinces that are looking at ignoring the Canada Health Act, I think we have to take seriously the threat. And I think the risk at this geopolitical moment also cannot be overstated. I think the fact that we do live next to the largest private health care insurance market in the world, the largest private for-profit healthcare provider market in the world, is reason to take these issues very seriously. We also learned very recently that the insurance, life and health insurance lobby association for insurers in Canada has been advising or involved in a quite intimate way with the Alberta government in terms of the implementation of Bill 11. And so this is the sort of the intimate access that we see with the industry lobby group that raises a lot of concerns about industry capture of government, its ability to have unfettered access in a way that public citizens do not have this kind of access. Civil society groups do not have this kind of access. So, it's all to say that I think it makes the the thinking about how we respond to this, and how civil society organizations and especially patient groups and those with complex conditions, while everyone is going to lose out with two-tier, it's really going to be harmful, especially to patients who are not wealthy, and many of us are not wealthy. We don't have the ability to pay out of pocket or purchase private health insurance. Keeping in mind in the U.S., personal bankruptcy for unpaid medical bills and medical debt is the single largest reason for personal bankruptcy in the United States still, even after Obamacare, which is being picked away at. So I think these are all reasons that we need to take this action and this legislation incredibly seriously. And I think first and foremost, uh, really ensure that the federal government, like Rebecca said, um, issues an interpretation and a clarification about this legislation. Because I think also putting a third of the Alberta healthcare budget into question it's supposed to be a significant carrot. It means that the Alberta government risks losing a third of its healthcare budget if it's not in compliance with the Canada Health Act. So I think, we certainly need to see the federal government stand up for the Canada Health Act, especially at this moment where our sovereignty is being questioned.
I can't argue against any of that. I'm fully behind that. I think it's not satisfying to people in the sense of like, let's go picket outside the premier's window. That certainly it never hurts, She does look out on 50,000 people, and that does happen once in a while around here. It can't change the fact that this legislation is on the books. But what we can try to do is, as a number of people have asked about, is really push hard on the organizations that do have that access, that do seem to have this government's ear, reluctantly or not, but they're possibly in consultations with the Alberta Medical Association. Can we push on those organizations to say, you need to push the guardrails now? What are those? First of all, something that ring fences the public system from this cannibalization, something that offers things we've been begging for decades, like minimum staffing guarantees, right? Actual, prioritizing scheduling and staffing within the public system first, rather than either leaving it to chance or, as the Rusnell piece I referenced, actively putting their thumb on the scale of this. Sorry, Jason, to prioritize private scheduling in the private sector first. We have to demand that through these organizations. We have to demand that these contracts are not going to be permitted to shamelessly cream skim the easiest high volume, low complexity and high profitability procedures and patients, that they won't be able to discriminate against patients, and that there will be meaningful caps on the types of billing that they can charge, caps on the services, and caps on the amounts. And when we ask, well, this works so well in Europe, one, it's not working well in our nearest competitor. The NHS opened the door to this a decade and a half ago, and they are scrambling to try to put all of these, locking these barn doors after the fact, to try to put some of these guardrails in post facto, and it's not working well for them. In other European parallel systems, they were designed with the guardrails first and designed to create a protected public system that works as well as the private stream. And unfortunately, the intention of this government is not to do that, because all of those pieces would have been in place to begin with. The intention here is to prioritize a private pay system, and we have to push back on the narrative of that.
Great. Thank you, Rebecca. And I think with that impassioned, both defense of public health care and call to metaphorical arms by all of us as Albertans. I think I'll probably bring us to a close. Just want to remind you before we finish off, and want to thank before I thank our speakers, is Parkland Institute. We get no money from the government. We don't want the federal or provincial. So what you see, the work that we produce, the work that we do is funded by folks like yourself who come to this webinar, who come and come to our events. And so if you like this report, you want to see more of this kind of work done, consider donating to Parkland Institute so that we can kind of keep Andrew and Rebecca biting at the heels of this government and trying to protect public health care. And so let me, as a final statement, thank Andrew and Rebecca for this important and insightful presentation and their report and their ongoing commitment to defending public health care in this province and this country. So I want to thank them for the time and their expertise and their time on this. And then finally, to thank all of you for spending an hour of your day to learn more about the risks to public health care that the bill presents and getting better understanding of the broader consequences of what may come of this. And so I say thank you and have a good rest of your day.